Hi everybody, my name is Greg Cook. I am the ID pharmacist at Children's Hospital in New Orleans. Today I'm going to talk about some pediatric considerations for the treatment of SARS-CoV-2. Starting out, I just want to reiterate that children are not little adults. So one thing that's going to be common throughout this presentation is there's going to be a lot of adult studies referenced. Unfortunately, right now we don't have a lot of pediatric data to necessarily guide our treatment, so I am going to refer to some of the adult data. This will be some highlights of the data, so if anyone is interested in more in-depth literature reviews on these specific medications, I would recommend checking out the other SIDP videos because they're going to go into much more detail than the highlights we're going to cover in this presentation. So we're primarily going to be focusing on some pediatric considerations of these medications. All right, the first medication we're going to discuss is Remdesivir. Remdesivir is an investigational agent. The mechanism of action is through the interference with viral RNA polymerase, which leads to premature termination of viral RNA transcription. So as I mentioned, the medication is an investigational agent currently available through Gilead for compassionate use in pediatrics with the link there. It's also available as an emergency use authorization. Currently, for the compassionate use application, Gilead does provide some inclusion and exclusion criteria, and these are at least currently up to date for the date of this presentation and recording, but they may change in the future. So currently, for a patient to receive the medication through compassionate use, they would have to test positive for SARS-CoV-2. They would have to have an ALT less than 5 times the upper limits of normal. They would have to be hospitalized with a O2 less than 94% on room air or supplemental O2. There's also some exclusion criteria, so patients cannot be receiving significant vasopressor or inotropic support. They can't be on VA ECMO, and then they cannot have a creatinine clearance less than 30, hemodialysis, or CVVH. A few pharmacokinetic highlights of the medication. So it is a prodrug that is converted into its active form. The active metabolite has a half-life of 20 to 25 hours, and then the medication is primarily eliminated renally. Dosing for Remdesivir depends on the age and weight. So for adult and children greater than 40 kilograms, the medication is a 200 milligram loading dose on day 1, followed by a 100 milligram maintenance dose thereafter on days 2 through 5. With that said, treatment can be extended up to 10 days for those that lack clinical improvement. And then for smaller children, so children 3.5 kilogram to less than 40 kilogram, the medication is weight-based with 5 milligram per kilogram loading dose, then 2.5 milligram per kilogram maintenance doses on 2 through 5, with the same caveat as that you can extend treatment up to 10 days for those that lack clinical improvement. And then this is, per Gilead, the exposure that's comparable to those observed in adults while limiting the exposure of the nucleoside analog. And then the same dosing is recommended for those that, as long as they have a postnatal age of greater than 7 days, their full term, and a serum creatinine of less than 1, the dosing all stays the same. One pertinent pediatric consideration here is of the Remdesivir formulations available. So there's 2 formulations available. There's the solution formulation and lyophilized powder formulation. So both are given intravenously, but there are different formulations. So for the solution, this is recommended for use in adults and pediatric patients greater than 40 kilograms. And then the lyophilized powder is for patients that are 3.5 to less than 40 kilograms, though it can also be used for the older patients as well. The solution is not recommended for those smaller patients. And that primarily is because of the excipient cyclodextrin. So to get the medication in solution, it really needs the cyclodextrin to break it down into the solution. So cyclodextrin, we're more familiar with this with IV voriconazole, and it's part of the reason why IV voriconazole isn't recommended in patients with renal dysfunction. But the varying amounts of cyclodextrin there. So for the powder, there's 3 grams of cyclodextrin per 100 milligrams compared to 6 grams for the solution. And then if you want to use voriconazole as a reference, there's 3.2 grams in voriconazole per 200 milligram dose of the IV formulation of voriconazole. So a little bit about the randomized controlled trial data for Remdesivir. So Act 1 is one of the published studies evaluating Remdesivir versus placebo in 1,063 adult patients. Essentially, what they found was there was a median time to recovery of 11 days versus 15 days for those that received remdesivir and placebo, respectively, and this was statistically significant difference. There was not any difference in 14-day mortality. But this primarily led to the medication being used and supports the data for use of remdesivir in SARS-CoV-2. Currently, there are some ongoing pediatric studies, but currently, as of the date of this recording, none of these studies are published or no data is available yet specific to the pediatric population. As far as safety data goes, so from this adult compassionate use studies, 60% of patients had some sort of reported adverse event in those studies. Most common was increased hepatic enzymes, diarrhea, rash, renal impairment, and hypotension. But with that said, this was a non-comparator study, so all of these are going to be confounded by COVID-19. In the randomized trial I just showed you, remdesivir was well tolerated overall, and there were a higher rate of adverse events in the placebo group than there were in the remdesivir group. And specifically speaking to the increased hepatic enzymes, AST and ALT elevation was found in 7.4 and 7.3% respectively, so really not much of a difference there at all between remdesivir and placebo. So moving on to the second medication, hydroxychloroquine. So hydroxychloroquine, it is an antimalarial and immunomodulatory agent. Currently, the proposed mechanism of action is through impaired viral receptor glycosylation and intracellular alkalization, inhibiting viral replication. And it also is thought to maybe play a role with reduced cytokine production and inhibits toll-like receptor signaling. So something going on with the immune system there. So adverse events of this medication do warrant some precautions. So the adverse events include rash, retinopathy, much more from prolonged chronic use, hypoglycemia, gastrointestinal disturbances, and QTC prolongation. The one I want to point out is QTC prolongation. So this does warrant some precaution if hydroxychloroquine is going to be used if a patient is on another agent that does prolonged QTC. Currently, hydroxychloroquine is supplied as tablets, which may or may not be able to be given to some smaller pediatric patients. So the medication, there is a suspension recipe available that can be made for patients that cannot take the tablet. So with hydroxychloroquine, there is some controversy on the appropriate dose. There has been some PK studies done that model this out for SARS-CoV-2. So for typical rheumatologic conditions in pediatrics, dosing is 3 to 5 milligram per kilogram per day, divided in 1 to 2 doses. Malaria dosing is a much larger upfront loading dose of 13 milligram per kilogram per dose, followed by 6.5 milligram per kilogram per dose at 6, 24, and 48 hours after that first dose. And then for COVID-19, there have been 2 proposed different studies and different modeling studies done that support different doses. So there was one done by Yao and colleagues that recommend 6.5 milligram per kilogram per dose twice a day on days 1, and then 3.25 milligram per kilogram per dose twice a day on days 2 through 5. And then there was a different study done by Downs and colleagues, which recommended mimicking the malaria dose in pediatric patients. But the caveat with all of this is currently there's really not a well-established pharmacodynamic, pharmacokinetic parameter, so it's really hard to determine the absolute best dose that we would recommend for COVID-19. One thing I do want to comment on is hydroxychloroquine and combination with azithromycin. So as I referred to in the adverse events when we were discussing the medication, that it isn't recommended to combine this medication with other medications that can prolong QTC. So with azithromycin specifically, there's really no data to recommend the combination of azithromycin and hydroxychloroquine. And then there are some potential harms for routine combination, which would include QTC prolongation, and then of course antibiotic resistance from use of antibiotics that are not needed. One of the studies that looked at hydroxychloroquine's efficacy was the recovery trial, which was done in the adult population. It's a randomized controlled open label trial. So essentially what they did is they compared hydroxychloroquine with placebo, and ultimately there, as you can see with the curve, that their hydroxychloroquine was not associated with a reduction in 28-day mortality. But one other thing that they did look at is increased length of stay, and that was associated with hydroxychloroquine, as well as increased risk of progressing to invasive mechanical ventilation or death. The next medication we're going to discuss is dexamethasone. So dexamethasone is a well-known corticosteroid. Mechanism of action is through anti-inflammatory properties as well as immunomodulation via multiple mechanisms. So for the specific study we're going to refer to for the recovery trial, this was done in adults. They use 6 milligram per dose daily for 10 days. If you're going to infer a pediatric dose from this, the 0.15 milligram per kilogram for a max of 6 milligrams daily would mimic this adult dose done in the recovery trial. And then for drug interactions, dexamethasone does sneak up on us. It does have some interactions with CYP3A4 inhibitors and inducers. For the side effects or adverse events of dexamethasone, these are all the well-known steroid adverse events, with including things like hyperglycemia and leukocytosis, to fluid retention and edema, as well as gastrointestinal bleeds, all the side effects that we're routinely used to dealing with corticosteroids. So for the recovery trial that I just mentioned, so this was the first medication that was found in the adult population to actually have a significant reduction in mortality. So this was the same, a different arm of the same study that I previously showed you with hydroxychloroquine. So here, dexamethasone reduced 28-day mortality among those receiving invasive mechanical ventilation or oxygen at randomization, but not among patients not receiving respiratory support. And you can see this here in the whisker plot that only the group receiving oxygen or invasive mechanical ventilation was found to have a reduction in mortality. If the patient was not receiving any oxygen, there was no difference from placebo. The next medication we're going to discuss is Lopinavir Ritonavir. So Lopinavir is a HIV protease inhibitor combination. Ritonavir here more so is acting as a booster to Lopinavir, not acting as a protease inhibitor itself, even though it does have those properties. And then the theory here behind Lopinavir Ritonavir is that it inhibits the protease of SARS-CoV-2, inhibiting viral replication. One thing that does warrant pointing out here, we do need to monitor these patients for drug-drug interactions, and that Lopinavir Ritonavir, given that we're giving a very strong inhibitor of 3A4, there can be a significant amount of drug interactions. So there is a resource here linked for you if you do have a patient that's going to end up on this medication. It is good to screen for drug-drug interactions. And then in terms of adverse events, so these are protease inhibitors for HIV, so pretty well-known adverse events here again, including GI distress, hepatotoxicity, QTc prolongation, as well as lipid elevations and fat redistribution. But most of these are all going to be from prolonged chronic use. The one we're going to deal with in an acute setting is likely going to be GI distress, which is going to include diarrhea as well as vomiting and nausea. The dosing for Lopinavir Ritonavir, so for the adult dosing there, 400 milligrams of Lopinavir with 100 milligrams of Ritonavir twice daily. For children, it's dose based on the Lopinavir component with 2 recommended doses. So you have a milligram per meter squared dose, or there's a weight-based milligram per kilogram dose, and both of those are going to be pretty equivalent, as well as some approximate dosing here that you could also use depending on how the medication is formulated and which formulation of the medication you're using from the tablets or the solution. Similar to dexamethasone and hydroxychloroquine, so the recovery trial has published some evidence and data on Lopinavir Ritonavir and COVID-19. And this was 1,596 patients that were randomized to receive Lopinavir Ritonavir compared to 3,376, which were just going to receive usual care. In this case, it was oxygen status at baseline. There was 4% were on mechanical ventilation, 70% were on oxygen alone, 26% did not require any respiratory intervention. Primary outcome here was 28-day mortality, and there was no difference in that outcome. No beneficial effects were seen in mortality or progression to mechanical ventilation or length of stay. Switching gears and switching into talking about multi-system inflammatory syndrome in children. So I wanted to touch base on this because it is something that's quite captured a lot of news headlines, and it does have some unique medications that are being proposed for treatment in children. So MISC for short, MISC is similar in presentation to Kawasaki's disease and toxic shock syndrome. So you might have patients that if they were to present with MIS-C, they may likely receive treatment for Kawasaki's disease if criteria are met. And then what I want to specifically discuss going forward is refractory MIS-C treatment. It's an active area investigation, but 2 medications have been proposed, including Anakinra and tocilizumab, which are being used similarly in the adult population for severe COVID-19 pneumonia. So the first medication is tocilizumab, and tocilizumab, it's a monoclonal antibody against human interleukin type 6, so it's an IL-6 inhibitor for short. Published use of this agent is limited to adults with COVID-19, so there's no studies necessarily evaluating pediatrics specifically. It is FDA approved for cytokine release syndrome and some other rheumatologic conditions for patients that are at least 2 years old. So dosing for COVID-19 pneumonia in adults is 4 to 8 milligram per kilogram per dose once, followed by a one-time repeat dose 12 hours if there's a lack of clinical improvement. There is a question in pediatrics, though, of should we use higher doses. So in children less than 30 kilograms, for the other pediatric indications, it is recommended to use 12 milligram per kilogram per dose. While there's no study evaluating this, I would say if you want to mimic the IL-6 inhibition that you're getting from the use of these other rheumatologic conditions, we would need to be using a higher dose in children that are less than 30 kilograms. So looking at the evidence for tocilizumab in COVID-19, so the first couple of studies that were published were all looking at different inflammatory markers, and you can see great reductions in those inflammatory markers after tocilizumab is given. In some of the earlier studies for this medication, essentially the authors came to the conclusion that toci, it effectively improved clinical symptoms and repressed the deterioration of severe COVID-19 patients. So while toci has been found to reduce a lot of the inflammatory markers that we will monitor in patients with severe COVID-19, there was one top-line results that have been released by Roche. So Roche is the manufacturer of tocilizumab, and they have a few phase 3 randomized trials ongoing. So the first one, Covacta, has released its top-line results. So Covacta is the phase 3 randomized double-blind placebo-controlled study evaluating tocilizumab in severe COVID-19 pneumonia in adult hospitalized patients. So essentially for their clinical result, the primary endpoint was the change in clinical status, and tocilizumab had no difference compared to placebo. No difference was found in 28-day mortality, ventilator-free days, and then time to discharge. While it was shorter in patients that received tocilizumab, this can't be considered statistically significant as the primary endpoint was not met. One thing I haven't mentioned yet for tocilizumab is the adverse events that tocilizumab can cause. So one of the largest ones that everyone's concerned about is a potential increase in the risk of infection. So here, the phase 3 study compared to placebo, they found that the overall infection rate was 38% versus 40.6%. And then for the severe infection rate, it was 21 versus 25.9%. So similar rates of infection between tocilizumab and placebo. What does this mean for pediatrics, though, as this was an adult study looking at COVID-19 pneumonia? So I will say I'm not quite sure what this would really mean for ultimately for patients that with pediatric patients that are presenting in MIS-C. Moving on to the last medication, Anakinra. Anakinra is a recombinant human interleukin-1 receptor antagonist. So it competitively inhibits IL-1 binding to the interleukin-1 receptor. Adverse events from Anakinra, so there is an increased risk incidence of serious infection with Anakinra, which is a black box warning on the medication. There's a risk of hypersensitivity, which is an additional black box warning on the medication. And then there also is injection site reactions. So the medication, as I'll show you on the next slide, is administered, at least FDA approved, to be administered subcutaneously, so it can lead to some injection site reactions. Other adverse events include headache, vomiting, as well as arthralgias. Drug interactions, one of the pertinent ones to remember here is that it is recommended to avoid live vaccinations after the medication is given. Anakinra dosing. So Anakinra dosing does vary based on the indication the medication is being used for. Routine pediatric dosing is in the range of 1 to 2 milligram per kilogram per day in 1 to 2 divided doses to start, and then that dosing can be increased to a maximum of 8 milligram per kilogram per day typically again in divided doses. When it comes to the dose for severe COVID-19 or MIS-C, largely the dose is undefined. So there's many different studies, retrospective as well as prospective, evaluating Anakinra for these indications. And the dosing is really all over the place. So some of the studies are evaluating intravenous dosing. Some of the studies are evaluating subcutaneous dosing. Most of the FDA-approved labeled dosing is subcutaneous. Some studies are looking at high doses, upwards of greater than 400 milligrams per day. Some studies are looking at doing lower doses of 100 to 200 milligram per day. One of the ones that was just published did 200 milligram per day divided in the 2 doses, and they did that for 7 days and then dropped down to 100 milligram Q24 for 3 additional days. But some other studies have looked at higher weight-based dosing, and largely is something that's just not well defined yet. The other question that does come up with Anakinra is, should we taper? So when we're doing these higher doses, a lot of these higher doses studies do taper the medication, but what's the ideal taper? How long do you taper it? All of these are questions that really are not answered yet. And then when do we need to taper? So if we're just doing a lower dose, do you have to taper that? So again, these are just questions that aren't necessarily answered yet for Anakinra. One last comment I did want to bring up is that there is a renal dose adjustment. So for patients that do have a creatinine clearance of less than 30, at least per the package insert, it is recommended to do every other day administration. In summary, right now we don't have a lot of pediatric specific evidence to guide our treatment of COVID-19 or MIS-C, so we really have to scrutinize the evidence closely. Given that there is no proven evidence-based treatment in pediatrics, we really have to consider the benefit-to-risk ratio of any medication used for COVID-19. And with that, thank you for taking the time to watch this video. And then if anyone does have any questions, my email is here in this slide, and feel free to email me. And thank you.